name's Dr. Jason Malone. I'm one of the pediatric orthopedic surgeons. I'm from Orlando, Florida with Memorial Children's Hospital. My talk's mostly gonna be on pediatric treatment of fibrous dysplasia in the skeletal system. I do talk about some adults, but because I am a pediatric surgeon, I'll kind of focus mostly on that. I have no disclosures. So an overview of my talk is we're gonna talk about surgical indications. Not everyone needs surgery, and you need to know when surgery is appropriate. We're gonna talk about fixing femurs or your thigh bones, tibias, which are your shin bones, the spine, leg differences, aneurysmal bone cysts. These are cysts or growths in the bone, and some other helpful information that I've discovered along the way with working with FD bone. So fibrous dysplasia, why are surgeons worried about it, and why are you guys worried about it? Well, it's weak bone. This weak bone has microfractures. This can cause pain and deformity, but you can also get true fractures too that can lead to more deformity. When do we not operate? We don't operate a lot of times, actually. If a patient has fibrous dysplasia but no symptoms, we want to monitor that. We don't want to just jump to surgery because many times surgery is not indicated. If it's a non-weight-bearing bone, let's say your hand bones or your upper arm bones, sometimes those don't need surgery. Sometimes they do, but a lot of times they don't. Or if it's a non-weight-bearing aspect of a bone that does bear your weight. And again, if there's little no deformity, we can watch. And how we do that in our practice with growing children, we take x-rays every 6 months. If there's no pain, we decrease activity if there is pain. So if a child's playing and they have pain, we stop that activity. And if there's a lot of pain, possibly place them on crutches or a wheelchair for a short period of time and see if that pain resolves. If the pain continues or does not resolve, that's when we start talking about possibly surgical intervention or medical intervention. So when do we treat again? Surgery, we do that when the pain or deformity increases or if there is a true fracture. And again, when we do surgery, we want to correct that deformity, but we also want to stabilize the bone, prevent a future fracture or future pain from developing. So we're going to get right into the femurs, the thigh bones. So we talk about doing surgery on kids when their femoral neck shaft angles. So again, we don't have a pointer, I think. Let me see if I have a, I do, but it doesn't show up on that screen, I apologize. So when you look at the neck of the femur and the shaft of the femur, that angle should be about 130 degrees. And when it's below 120, what we know is that the mechanical alignment of that leg is now off. And when your body weight is on it, it's gonna keep on making that bone bend and bend and bend. So we wanna protect that and prevent that from happening for most children. So for children who are under 8 years old, we usually do an acute osteotomy. So we make a break in the bone and we repair it with a plate and screws. This holds the bone in place until the bone is healed. Sometimes the bone is so poor in its mineralization or its strength that we do supplement it with a cast such as these here. They're called spica casts. But not everyone needs one of these. And some kids, especially with very poor disease or with phosphate wasting, require multiple revisions. And this is always a talk with families about if this is the appropriate thing to do for your child, and keeping the bones in a proper alignment can continue to allow a child to weight bear. For children who are over 8 years old or for adults, we do look to use an intramedullary nail. So this is a nail that goes inside the bone. There is usually a canal in adults who do not have fibrous dysplasia, but with fibrous dysplasia, there may not be a canal. But there are different types of nails that we can use. This one that we have here is an adult type of nail where it protects the femoral neck and it protects the shaft of the femur. And we can use that after we reconstruct, or we even use it in children after we repair it with a plate and get it in a better alignment. A year or two later, we can replace that plate with the nail to again protect the whole entire femur. For young kids, again, who are still growing, there are these rods called Fossier Duval rod, named after the doctor who invented them. And these are telescoping rods. So the proximal piece, or the top part, attaches to the epiphysis, which is the top part of the bone. The bottom part crosses a growth plate and attaches a growth plate. And these can expand, as you can see on the right side of my picture. And again, I wish I could point to it. But the male and female end separates, and it can continue to protect the femur. The problem with these ones, though, is it does not protect the neck. And just anecdotally, again, this has not been studied in depth, we have noticed that these don't really anchor into the bones as much as we expected. These were invented for osteogenesis imperfecta, another weak bone disease. We've been using them for fibrous dysplasia, but again, the anchors don't seem to hold as strongly because with osteogenesis imperfecta, the bone is brittle, so it breaks kind of like chalk, but it's a little less spongy than fibrous plastic bone. One thing we also don't recommend is using bone graft in children. We do use it if there is a cyst or we need to fill a void. But to expect that when a growing child to replace the polyostotic bone with healthy bone, that usually doesn't happen. So there is a nice study by Leet and Boyce and their team done in 2016 where they kind of showed that with young kids, when you place the bone graft, it's sort of reabsorbed over time. And for young kids, it reabsorbs very quickly. For adults, most of it reabsorbed, but it could take 5-10 years. So we will use bone graft when there's a cyst or if we need to help our construct. Like this individual here had it for helping control that proximal femur. There's not a lot of bone in there. The bone graft is placed there to help that construct to protect the femoral neck. But just be aware, if it is used, it's going to turn right back into fibrous plastic bone. Kids really early, adults much later, but it will most likely turn back into the abnormal bone. Also, a recent study again by Dr. Boyce and Collins and some few other people here is that they study the risk factors for who really is going to have progressive coxivara. Like, who do we really need to do surgeries on these kids? And it seemed like, again, younger kids who have more involved disease, so having both sides involved, those who had, again, worse disease, which means worse bending of the neck, the calcar being involved. And the calcar is the really strong part of the bone. Again, I wish I could point. It's that, if you look in that picture on the very right-hand side, the very thick bone. Strongest part of our femoral neck. And if that part is involved, then the femoral neck can displace. So that was shown. And then again, the more severe disease you have, if you have McCune-Albright, precocious puberty, growth hormone excess, phosphate wasting, anything like that, all that leads to the femoral neck bending more. So we do have a case of, I'll show you some cases that we've done. So here's a 10-year-old patient with polyostotic disease, bilateral, and this patient presented with increasing right femur pain. So previously had a phosphated all rod, but if you look at that right femoral neck, it's now down to about 90 degrees. Again, we wanted around 130 degrees, and again, once it gets under that 120, it keeps getting worse and worse. The left side, you can see that rod, the phosphated all rod, is protecting the femoral neck. There is still a fracture, but it's not too displaced. But just like what I was talking about with our anecdotal evidence, you can see that distal piece, the part closest to the knee on the leg, is no longer where it's supposed to be. So see if you look at the two femurs, where the rod is, it's not equal. So they're not really anchoring as much as we hoped. So here again, just a close-up of that femoral neck that we were talking about. So this patient was treated with a plate and screw, just what we were talking about. We did an osteotomy, corrected it. We put some rods up the nail. These are flexible nails to try to protect the rest of the femur while the neck was healing. We use this technique because we really wanted to overcorrect. With the rods we have now, we can't overcorrect. The rods are made for a normal femoral neck angle, so we wanted to slightly overcorrect, so that's why we chose for this patient to use the plates. The left side, you can see again, there's a deformity in the femur. This we treated a little differently. We used the adult type of nail where we put a rod down, protect the femoral neck. This exact rod only had one screw that goes into the femur. And again, this will not anchor distally, but it does protect most of the neck, but again, or most of the femur, but it doesn't grow with the patient. We'll talk about tibias now. So tibias too, they can also have fibrous dysplasia and they can deform. When they start bending, they become painful and becomes harder to walk. So how do we treat these? So usually kind of the same way. We do an osteotomy or breaking the bone to alignment, and we'll try to correct it with a rod when possible. Again, this prevents deformities and allows the patient to walk and also adds strength to the bone. Again, different ways we can do it. The phosphated all rods like we talked about earlier. And we again, this is, the phosphated all rod is the one in the middle. It has, again, that expanding rod. The same company makes a solid rod. That's the one to the right. That's called a slim nail. It does not expand, but it is actually a little bit stronger. So these rods are, the strength is based off the material that they are. These are stainless steel, but also the radius, so how thick they are. So the solid nail is thicker and it doesn't expand, so it should be stronger. So for some kids who, they don't anchor distally, we will put these solid nails in. But for this patient, you can see we put a phosphated all rod in again. Hopefully that the kid can grow and it will expand with them. This is an adult style nail, and you can see the severe disease, but the leg is being held in a good alignment, and those rods don't grow with the patient, but they do a good job, again, preventing future fractures. This is another patient that we have treated, so different x-ray. And again, sometimes the deformity is so bad we have to do what's called a sole field osteotomy, where we make multiple cuts, almost make it kind of like a shish kebab to line that bone up. And this is one we've done. This is not a phosphated ball rod. This is that slim nail, the one that does not anchor. And here's just another kid that we have. That's just a child with pain. That tibia is deforming. The left picture is of the side view. The right picture is the front view, but you can see that tibia is bowing. We did an osteotomy and put that phosphated ball rod down when the child was 11. At 12 years old, you can see that distal piece, again, that rod is no longer in the ankle like we expected it to, but the bone did heal, the deformity is corrected, and it's still protecting the bone. So for scoliosis, really scoliosis can almost be treated like idiopathic scoliosis with some caveats. We do know that the higher disease burden, so the more fibrous dysplasia you have in your spine, the more likeliness your curve is going to progress. Studies, again, done by the NIH, have shown that bisphosphates do not slow down the progress of the curve. And that there's a study, again, by the NIH and Dr. Stanton sitting back there, showed that they treated 12 patients with fibrous dysplasia. Most did very well. The fibrous dysplasia and the curve the curve was corrected despite the fibrous dysplasia, but 10% did have some failures that required a repeat surgery. So our recommendations, if you do have fibrous dysplasia and you're having worsening scoliosis, again, the indications for scoliosis surgery is when your curve is greater than 50 degrees or if it's rapidly worsening. So if you have a small curve, you don't have to do anything about it if it's not worsening. We do recommend getting a CT scan or an MRI to look at the entire spine to evaluate the areas for fibrous dysplasia. And if you have the availability or the hospital has intraoperative CT scanners, which is called an O-arm, you can use that along with navigation to actually bypass the fibrous dysplasia or put in a safe spot. Trying to use more hardware. Some hospitals use, we call them we all use pedicle screws, but some hospitals try to save pedicle screws. That's the cost of the surgery is based off of the metal that we use. So those screws that you see, those kind of circles, some hospitals will try to skip levels in an idiopathic patient to save money for the patient, for society, and for the hospital. But for fibrous dysplasia, we recommend pretty much using it every level you can because of the bad bone. And you can also use bone cement. So I got some pictures of this stuff. So here's the bone cement if you can't skip levels. And there's many different ways of doing it. They have special screws that you can put the bone cement through. You can make a hole in the bone to put the screw down and then put cement around, then put the screw in. And there's even ways that you can put make a hole for the bone and then expand it with a balloon and then fill that with cement. So your surgeon can have different techniques. This is a study, it's on the bottom, that tells your surgeon what are the strongest techniques as well. I can also share that with anyone if anyone's interested. This is an intraoperative CT scan. We call it an O-arm because it looks like a big O. This allows us to scan the spine before surgery. And then with that information, we can actually navigate or put these screws into the bone and stay out of the spinal canal and into hopefully strong bone. So this is becoming standard of care. Not every hospital has it. These machines are about $1 million. So not everyone has them yet. But when you do have it, it works really well and it makes surgery safer. So we do have a case that Dr. Stanton did, a 17-year-old patient with polyostotic disease with a 58-degree curve. It was worsening. Here's that curve. We have a CT scan of the spine, and if you can see on the left view, all those kind of black spots in the spine are fibrous dysplasia, so fibrous dysplasia throughout the spine. Oops, sorry. And then here's the curve. So you can see he got a nice correction. The curve stabilized, the spine healed. And the pain and the deformity did not come back. And that's 1 year after surgery. So now we're going to talk about leg length discrepancy. So leg length discrepancy is actually very common in the population in general. Most of us have at least 1 centimeter leg lengths that are different. Studies have shown anywhere between 1 to 2 centimeters is normal, and we probably start feeling the difference around 2 centimeters. Either we walk a little different, we have back pain, hip pain, but most people actually, we took x-rays of all of our legs, none of us are perfect. So we usually recommend non-operative treatment for most patients, and there are treatments that we can do if the leg length discrepancy gets over 2 centimeters, or again, if it's too much, over 5 centimeters. But most patients can use a shoe insert if it's less than 1 centimeter, or a shoe lift up to 5 centimeters and still be very comfortable. and that's the normal recommendation. If a patient or a family decides to have surgery, and the child still has growth remaining, there is a thing that's called an epiphysiodesis, where we actually remove the growth plates in the longer leg. So the child has to be growing. Most girls stop growing at 14. Most boys stop growing at 16. That's just on average. But we can time it right, where we know if we follow the growth of a child, we can find the velocity or how much growth they have. And we can try to lower that growth. With fibrous dysplasia, and if the fibrous dysplasia, if the leg has that fibrous dysplasia in it, or the longer leg, our normal numbers may be slightly off. So our estimates may not be perfect, but it is an option to even get the legs closer if a child is growing. But again, the timing is important. For skeletal mature individuals, there are lengthening procedures and shortening procedures. The shortening procedures will actually remove a wedge of bone, and you can actually shorten the leg. That is actually the safer way of doing it. If you shorten a leg, you don't want to shorten it more than 5 centimeters. Again, that's going to make the muscles be weaker. So if you shorten a femur as well, you can also throw off the mechanics of the leg. So the tibia, the mechanics are straight up and down. The femur kind of bends a little bit. So if you do a shortening, it is available, but you don't want to shorten too much, and you want to be aware of the secondary deformities that you can cause. And you can also lengthen a leg. We talk about lengthening legs for individuals who don't have fibrous dysplasia when that deformity is greater than 5 centimeters, or if you're an adult and you're no longer growing. There are case reports of lengthening in patients with fibrous dysplasia with good results. Things you have to think about if you're going to lengthen is that you have to protect the joints. The hip can dislocate, the knee can dislocate, the ankle can dislocate as you're pushing the body faster to grow than it ever has before. You can cause stiffness. With a weak bone, the metal can break, the bone can break. And again, there are good case reports showing that this is safe. There is one case report, though, from I think the 90s that showed one patient had malignant transformation many years later. So saying that they had cancer in that bone later on. Is it related or unrelated? No one knows, but that's just a thing you should have in the back of your mind if you're talking about lengthening through fibrosplastic bone. So here is the highest case theory that I've seen in the literature. So they lengthened 8 patients. They followed them for 2 years, and they lengthened with an external fixator, but stabilized it with a rod inside. And they had good results with only one patient needing a revision. So with an external fixator, it's a frame outside your body. There's pins going through your skin and your bones. This leads to some problems with skin irritation. Most people don't like something outside their body, but that is an option. And again, this had decent results with just one revision after, but again, only 2-year follow-up. There is an intermedullary nail, a nail that goes inside the canal. This has, again, a male and female part to it with a magnet and rods, and you can actually lengthen the leg through this way. It's a little bit less morbid because there's nothing going through your skin, and families seem to like it for if they don't have fibrous dysplasia. It's been well studied in normal bone. We do have a case that we did lengthen a child, or I should say a young adult, an 18-year-old male who had a 5-centimeter leg length discrepancy, and he had polyostotic disease. So you can see these are his x-rays. His right leg with the disease is a shorter leg, and you can see he's had multiple hip surgeries with not a great femoral neck, but still a femoral neck that's in acceptable alignment. So we decided to leave his plate in, trying to protect that femoral neck. We put a rod up, and we were excited because we were able to sneak that rod around his screws, and we were even able to use his plate to place a screw through the nail. So we were sort of excited that we kind of used both metals together. We were lengthening him, and then what we noticed along the lengthening time, again, you lengthen 1 millimeter a day, we lengthened for 35 days. And he started having a little pain in his hip. We got x-rays, and we noticed that he actually broke around our screw at the very top. So we stopped lengthening, we let him heal where he was at, and he did achieve a 3.5 centimeters difference. So now he's only 1.5 centimeters difference. He only has to use a shoe insert, but we didn't get that 5 centimeters that he really hoped for. So he was happy. We have to take that nail out, so it's a second surgery to take the nail out. It's got a magnet in it. We don't know what the magnet will do for your body your whole entire life. We kind of talk about if you put a phone in your pocket for the rest of your life, what will happen? So the manufacturer recommends that metal comes out. So we took the metal out, put in a non-expandable rod to protect his femur, and he's now 19 years old. The last time we saw him, and he was doing well, and he was very pleased with his surgery. And you can see just the healing there that he had done with the lengthening. So one of the other things I want to talk about, kind of last things about bones, we want to talk about aneurysmal bone cysts. So these are bone cysts filled with bone, or with blood, and they can expand, and they can destroy the surrounding bone. On MRI, it kind of shows us the best view, and this is a picture on the bottom right. That is an MRI of a calcaneus or heel bone. And what's kind of neat with these ABCs, or these aneurysmal bone cysts, is that when someone lays in an MRI machine, it takes a little bit of time to get that MRI. So what happens is, you're not seeing this, but the person is laying down. Let me see if I have another picture of it. This person's laying down, but the serum actually separates from the cells. So there is a thing called pathognomonic, or something, when you see something, that's what it equals. So when you see these fluid levels where there's more white on the top and black on the bottom of the cyst, that means it's a cyst full of blood, because your cells have separated from the serum. So that's what we can see in pretty much any bone. There's not many studies that show where aneurysmal bone cysts appear in fibrous dysplasia, but it does appear to be more common in the skull, but that is possibly future research that can be done. We have a patient who is 6 years old with polycytic disease. Only his right side was affected, and he was asymptomatic the first time we met him. This is his x-rays with it, his femur involved, tibia involved, no deformity. His right leg is longer than the left. He got a shoe insert. We kind of followed him for many years, just those 6-month x-rays, no surgery was needed. There's his tibia involvement, as you can see on the right side, no deformity. Around 11 years old, so a few years later, he started developing tibia pain. If you look at his tibia, there's now a new lucency, or a little black spot right in the middle of his tibia. So I'm kind of pointing it out there with that arrow there. And so we decided that was an aneurysmal bone cyst because it was expanding and becoming more painful. We went into surgery, we excised the cyst, put bone graft in there. We do know that bone graft is going to fill back in with fibrosplastic bone, but fibrosplastic bone is better than a huge hole full of blood that's expanding. So that is an adult style nail that we put in through the medial side, and we protected the tibia. And this is him about a year later. He was doing quite well from the tibia surgery. But then he started complaining of some right femur pain. So as we look at his femur, on the lateral view, you can see that there is some new lucencies and expanding of that kind of cystic area of the right femur. An MRI was obtained, and it was full of aneurysmal bone cyst. So this one is not as pathognomonic. You just see mostly the serum in it, not so many cells, but it's full of fluid, if you can see right there. So he, again, went back a year later from his first surgery. We took out the cyst in his femur, put an adult-style rod down his femur, and protected his femur. His femur is healing well. He's getting older. He's still having some pain in his legs. We're talking about medical management for his pain right now. But the bone cyst has not recurred. And it's been about maybe 9 months since his last surgery. So things that I've learned as being an orthopedic surgeon and working with kids and working with fibrous dysplasia is that you need to find, if you have a child with fibrous dysplasia, a good orthopedic surgeon. There's not always orthopedic surgeons that know about fibrous dysplasia, but hopefully they're willing to learn. And ways that you can ask them if they know about fibrous dysplasia, ask them how many patients they've treated. Ask them if they can name any other syndromes that are associated with it, like McCune-Albright's or Mazebraun, or anything else that they can think about. And if they haven't been familiar, are willing to learn. And again, the best practice guideline, you've seen that already today, you can print this up and give it to them. And most doctors are willing to learn. And we too, myself and Dr. Sand, are willing to always talk to doctors too. We get emails all the time asking, what would you do in this situation? Because again, fibrous dysplasia and treating this in growing kids is not that common for most orthopedic surgeons. We don't see it in our training. Having a good endocrinologist, we don't live in a vacuum. We need a good team. So getting a good endocrinologist, a good primary care physician helps us out a lot too, because if you're doing phosphate wasting or your growth hormone is not working, I can fix your bones all day long. They're just gonna keep getting worse and worse and worse again. So we do need a good team to help us out with treatment. Things that you can tell your surgeon if you're gonna have surgery, one, besides getting a good endocrinologist and making sure you're medically managed, is use a tourniquet if possible. This bone bleeds a lot, unlike other bone. If they've never treated before, they'll be surprised how quickly it can bleed. Try to perform the surgery quickly. Myself and Dr. Stan do it together. We can do it quicker with 2 surgeons. So the faster you do the surgery, safely and fast, the least amount of bleeding you'll have. Use bone wax. Bone wax is paraffin wax that is sterilized, and we can actually put that on bone edges to stop bleeding. So we do that on areas that we can that we are worried about that won't stop bleeding. We use a thing called Cell Saver. It is a vacuum that sucks up your own blood. All surgeons use pretty much a suction that removes the blood so we can see where we're working. But a Cell Saver is a vacuum. It collects your cells, and if there's enough blood that's returned, we can actually give you a self-blood transfusion. We use a medication called tranexamic acid. It's been used recently for total joints, total hips, and big surgeries that there's a lot of bleeding. We've been using it, and anecdotally, I think it helps. What it does is it stabilizes blood clots. It doesn't cause blood clots, but if you have a scab or a blood clot, it helps stabilize it so your body doesn't break it down faster. And then what we found too with a database study that we've been doing, that 14% of patients who had orthopedic surgeries needed blood transfusions. For most of our surgeries, it's less than 1%, but for children with fibrous dysplasia, it's about 14%. So if you're gonna talk to your surgeon, they've never worked with it, just let them know, and they may need to have blood available in case you do need a blood transfusion. And again, the bone is weak, so try to use an intramedullary nail if you can. For young kids, again, it may be impossible, but for an adult, a nail can help stabilize the bone and prevent future deformities. Again, we use locking plates when we can't use a nail, but try to replace it with a nail when you can. And use supplemental casting if the bone is too weak. And that bottom picture is a piece of bone that we took out, sent to the NIH, and you can see how weak that bone is. You should not be able to see through bone. Bone should be solid. If you've ever eaten a chicken bone or steak, that bone right there, you can see right through it holding up to the light. Also, having poor bone or weak bone means bad x-rays. So during surgery, a tip for your surgeon is make sure there's nothing under the patient. Any blanket or anything else on the patient can make the x-rays terrible. Use a special table that's radiolucent so you can see through it, and make sure you have good x-rays before you start surgery, because if you can't see what you're doing, you're not gonna have a good outcome. And again, you may not have an intramedullary canal or a canal to put the rod down. I keep saying put a rod down, but sometimes there's not even a rod there. They do sell these hand reamers, that's the picture on the left, where you can actually make your own canal. I'm pretty savvy at making my own canal, but not a lot of people are. If they're not savvy, there's a way to actually make a break in the bone and make a canal going up and down. So you kind of bring the bone ends out and you make your own canal. But some surgeons will get in there thinking they're gonna put a rod down. You see the x-rays, it looks like there's a canal, but there isn't one. So let them be aware, and there are ways to make one if you need a canal. And again, we don't really use bone graft that often. We will use it for cysts or filling a gap, but in children anyways, it will turn back into fibrous dysplasia. In adults, it may take multiple years, but it usually, in the end, it turns back to fibrous dysplasia. And just a final tip, surgery really is a discussion between families, the surgeon, and your whole team. Not everyone needs a surgery, and we do think that kids, when they're in their early, 11, early teen years, they can help make that decision, because some surgeries do take a long, long time, and some patients can't even have surgery. The picture on your bottom, I don't know if you can see that, it kind of doesn't show up that well here, but that proximal femur is just a big ball of bone. There's no way that we can fix that. So it's a discussion between everyone if it's valuable for your child to walk or not walk, and if the multiple surgeries are needed. And we do want to listen to our patients and our kids when they get old enough to help us decide. So just be aware that it's a teamwork, and no one should ever force surgery on you. Finally, my last shout out is to, if you're having surgery, the NIH has bone sample kits. So they'll send a kit to your surgeon, and any bone that they can get, they can use for research. So every time we do a surgery, we send kits back to them. So be aware if you're having surgery or getting not just a biopsy, that's not enough, but a reconstructive surgery, have them send some to the NIH so they can do some research and hopefully find a cure. So here's our hospital. My email address is on the bottom. I apologize, it got kind of cut off. My name is Jason. So my email address is jason.malone@nemours.org. And here are all my references in case you need them. The slides are available. Feel free to ask me for them, or Tova, we can send to anybody. And all that research I talked about, you can share with your surgeons or your team. And this is our beautiful hospital. I love it. So I just like pointing out our hospital. These are each patient's rooms. And so our families helped to design our hospital. So one thing that kids hated was that the rooms weren't theirs. So you hang up posters, you put up stuff in your room. So each kid gets to pick the color of the room. So they can turn all the lights into whatever color they want. So it's pretty neat when you drive by the hospital and every kid has a different color in the room. So it makes me kind of smile and makes the kid have their own room. Yes, we have a question in the front.
have you followed any of these kids? Does it change their quality of life? Are there things they can't do?
So it depends on how big the curve is. So in an idiopathic curve, a normal curve that doesn't have fibrous dysplasia, if the curve is under 50 degrees, it doesn't change the quality of life. The curve does not get worse. We have old data that showed after it's greater than 50 degrees, the curve progressed 1 degree a year all the way to adulthood, like past adulthood. But that data is kind of coming into question if that's true or not. So we recommend surgery when the curve is over 50 degrees or if the curve is worsening. So if a curve is 20 degrees and hasn't changed in years, there's no back pain, there's no reason to keep on x-raying in adults. But we do recommend that the primary care doctor keeps watching the back, make sure it doesn't look worse or not having increasing pain. But if you're seeing increasing pain or you're very close to that, say 45 degrees 50, but you haven't had surgery, you probably should still follow up with a spine surgeon just to make sure it's not getting worse, especially if the back is full of fibrous dysplasia. But everyone's different, so it's kind of hard to generalize. Yeah, Mike.
Jason, when you do osteotomies, especially when you do shish kebab osteotomy, do you get damage to the blood supply or the nerves? Is there loss of sensation or things like that?
Yes. So Mike, I'll just answer his first part. So when we do the shish kebab, the soul-filled osteotomy, where we take the bone, we actually remodel it. It's really interesting because kids have a huge periosteum. That's the covering of the bone. Adults don't have it as well. So in adults, if you completely devascularize the bone, it can die. In kids, we can actually take those out and the blood supply is still left on the lining of the bone. That's the periosteum. And there's not much, like I would say, nerve like sensation in the bone itself. There's proprioception and there are so pain receptors, but as in like sensation-wise, that's all on the skin. So when we do that shish kebab thing, it should not change your sensation of your tibia or your lower leg. We do have to be careful when a bone is curved on the concave side or the bent side, so like the U side, the bottom of the U side, if there's nerves or stuff on that side, we make a leg straight, you can actually stretch the nerves out. So a lot of times too, Bob and I will shorten a leg that's too bent to protect those nerves, or you can do what's called neuromonitoring, where you actually put little wires in their nerves and watch it as you stretch. So yes, for adults, we can cause devascularization, but no, it shouldn't affect the nerves. Kids, they should be okay, and just always shorten it if you're fixing a big deformity. And that's with one of the kids that you see sometimes a fibrosplastic bone, the leg is longer because that bone's growing a lot. Sometimes it's shorter because of us, because we have made it shorter, fixing deformities. Yes, question back there.
Is it more technically challenging operating on bone that has a lot of fibrous dysplasia in it than normal bone? And in my experience when I was growing up, there was a lot of orthopedic surgeons simply didn't want to touch me. They thought it was too technically difficult to fix my shepherd's crook deformity.
You're right. And the shepherd's crook deformity is very difficult to treat. So if you don't, we try to prevent the shepherd's crook deformity. So for those who don't know, that's when the proximal femur, again, I use my hand all the time as an example. So your femur has a head, a neck, a shaft. And as that neck goes down, when it's like 90 degrees, it's still fixable. But the shepherd's crook deformity, it looks like a cane. It's where it gets so bent that it's almost impossible to correct. The reason being is where it's deformed is the femoral neck. That gives the blood supply to the femoral head. So we don't correct it where the actual deformity is, we correct it more towards the shaft where the blood supply is safe. If it's too bent, if we try to cut that neck, we can actually cause arthritis or destroy the femoral head, and then that doesn't help anyone out. So we do try to prevent it before it becomes shepherd's crook deformity. But yeah, orthopedic surgery is technical. That's why we trained for 5 years, but it does get even more technical when there's a bigger deformity and fibrous dysplasia, because again, most orthopedic surgeons have never seen it in their training. So if you're an adult and need some kind of deformity correction, usually the tumor doctors, the orthopedic oncologists, have a little bit more experience with soft bone or deformities that they need to correct.
I have observed a few cases of young patients in their 20s who had vascular osteonecrosis of the hip. They had FD at the hip. And my question is, have you observed as a surgeon anatomical vascular abnormalities in those patients that would be a risk factor for this avascular necrosis?
So you're saying you see a lot of avascular necrosis in people with FD?
Yes, FD involving the hip. Generally, not really severe patients. Some of them had preventive surgery, were nailed, some others were not. They developed hip pain, and this was avascular necrosis, and they had no other risk factors for necrosis like corticosteroid use, diving, etc.
I have not had experience with that yet. I've been practicing for about 6 years. Bob Stanton over there has been practicing for a lot longer than I have. We also don't follow kids after 21. So
Yes,
we
sure.
lose a lot of them. And that's always one critique from our adult colleagues, that we do all these surgeries and stuff, but we don't see the long-term follow-up or the long-term outcomes. So I have not personally seen it. My experience is that bone is very vascular. It bleeds a lot. And the healing is actually amazing. Just like kids, they heal well. We have never, I'm going to knock on wood, I've not seen a non-union between the bone does not healed. I have not seen avascular necrosis, but maybe Mike has some answers. And Bob was shaking his head no as well.
I was going to weigh in, and I think we've seen like over 300 patients now at the NIH, and I don't think we've ever seen a single case, maybe one, of avascular necrosis. So it's certainly not a common feature of it. Just to weigh in, I don't know.
It'd be a nice study. I mean, these are things that we love, like these meetings for, to look at and study. Avascular necrosis can happen to anyone. For some reason, people can lose the blood supply to their femoral head, and it can be idiopathic, which means we don't know why. It can be caused by having some type of clotting disorder. So you make too much clots, and then you disrupt the blood supply. So it'd be interesting to see if there's any other thing that's going on and comparing them to the other population, because it's not uncommon, especially if you have like sickle cell or something that makes the blood not flow to the head. Or smokers. Any other questions? Okay. Well, thank you guys. I appreciate your time.